I'm excited about week 4 here. We're going to be talking about interoperability in healthcare, ITech 770. So I'm going to share with you the PowerPoint. This has a few slides. This will just take a second. There we go. All right. Interoperability in healthcare, trying to bridge the information gaps. I feel like we're at the precipice of a very important time in healthcare. Healthcare in America offers so many challenges. It's the most expensive in the world and yet of the lowest quality. And I hope that some of you in this class will end up being some of the leaders that help change the system so that we can make the system more accessible, more equitable, and of higher quality and much lower cost. So these problems are massive. And in my opinion, the healthcare system in America is actually threatening the entire economy. If we spend nearly 20% of our gross national product on healthcare, that means we can't use that same productivity for other endeavors, such as manufacturing or research or building important things, getting us to Mars. All of this money, this 20% of the gross national product that is spent on healthcare, is essentially a tax. It's a drain on the economy. And we all pay the price. The various components of the healthcare delivery system are getting their ounce of flesh. They're getting their money, but we need to figure out how to make it more equitable and get more bang for the buck. So let me start the PowerPoint. Here we go. All right. And I think one of the major problems we face in healthcare is that you have some very powerful players in the market space. I think the three largest are the insurance companies, the hospitals, and big pharma. As healthcare in America became more fragmented, we realized that something was going to have to be done to do a better job of organizing healthcare. What happened is, over the years, the hospitals became more and more profitable. When I graduated from medical school, the hospitals consumed less than 10% of the healthcare budget. They're now up to 35%. And so when you're talking about a $4 trillion industry, that's a lot of money. And with all of that financial impact comes a lot of power. And so as we realized that patients were having an increasingly difficult time transitioning from one healthcare provider to another, whether it's individual doctors or whether it's urgent care centers, X-ray facilities, imaging centers, laboratories, specialists, hospitals, surgery centers. Anytime the patient makes a transition from one provider to the next, there's the opportunity for having loss of coordination of the care and sharing the information from what was learned at the last stop. And so the concept of interoperability rose over the last 20 or 25 years. And here's the definition from the National Coordinator for Health Information and Technology, the ONC. Refers to it as the ability to two or more systems to exchange health information and then to use the information once it's been received. So we're trying to provide timely and seamless portability of the information. That way we can optimize the health of individuals and then therefore globally the entire population. So it's critical for effective healthcare delivery for us to be able to share the information. There is so much medical information that's acquired. The trouble is there are very few standards about how that data is acquired, and therefore, anytime you go from one system, health system to another, the opportunity for being making the process of accessing and utilizing the information from the previous site very difficult. So that in the early 1990s, the initial standards for data exchange were promulgated, and then in the 2000s, 2010s, we've seen a massive expansion of the use of computers in healthcare. And here's a brief history of the federal interoperability efforts. This is a slide from CMS, the Centers for Medicare and Medicaid Services. That's the government that pays Medicare and provides the budgets to the states for Medicaid. So back in 2009, Congress passed the Health Information Technology, HITECH, and established an incentive for doctors to start using electronic health records. Doctors would get dinged 3% of their normal Medicare reimbursements if they did not adopt electronic health records. And the difficulty, I was a primary care provider at that time, and the difficulty that we faced was that these electronic health record systems were massive pieces of software, and they didn't come cheap. And so there were sometimes various vendors that provided important services to the clinic that sometimes would offer a free electronic health record. And so there were so many small electronic health record companies that sprouted up to try to help the doctors meet these high-tech requirements. But on the other side, you had the huge hospital systems that were buying up doctors' offices. And when you went into the hospital environment, you were forced to use their information infrastructure. And a lot of times this was a very expensive transition. And as a result, the doctors lost their ability to be able to maintain private practices financially, and they all ended up being progressively gobbled up by these massive health systems. So one of the challenges of the electronic health record has been the competing goal to keep security, have data security and privacy for all the patient information. And there are another set of laws about HIPAA that protect the patient's information from unwanted exchange or divulging into the system. And so I think the HIPAA laws and the privacy and security laws have been a tremendous detriment to medical research, because everyone is terrified that someone will have a data breach, and the punishments are draconian. So as you can see, in the last several years, 2020, 21, 22, 23, there have been tremendous amounts of efforts of the various governmental organizations and industry associations to try to come up with standards. And the first big standards that were promulgated was what's called HL7. And actually, a colleague of mine, Dr. Ed Hammond at Duke, he was my mentor when I first got into the medical informatics. He's been the president of HL7 not once, not twice, but 3 times. And I just went to his 90th birthday party up in Durham a couple weeks ago, and we had a great time. But all the big pundits were there and talking about how we've gone from HL7, and since HL7 was not very effective at allowing patients' data to be able to migrate from one care environment to another, they added a second subsystem to it called FHIR. And we'll go into what FHIR is a little bit, but it's really a subset of the data that's captured in most electronic health records that they've tried to standardize to say that all the different vendors have to be able to communicate at least these variables, at least this subset of the data that they capture, in a format that allows them to communicate from one hospital information system to another. So what's the current need? What is the need at the hour? Why is interoperability important? Well, what are the barriers? The barriers are the fact that the hospital information systems are so huge. These are multi-billion dollar uh, um, entities, and for a while there was an increase in the number of hospital information systems that developed because of the profit and the demand for such systems, and a lot of them were sort of homegrown. As a matter of fact, Epic, the biggest one now, was homegrown at a local hospital, and the lady that did the initial software development was smart enough to get the hospital to allow her to have the rights to the software, and she ended up selling it to other hospitals, and it became what is now Epic, is the largest hospital um, electronic health record system in the country. For a while, there were two competing entities, the Epic and Cerner. Cerner was bought by Oracle a few years ago for many billions of dollars, and now Larry Ellison, who owns Oracle, is also now owns Cerner. But at the same time that happened, the Epic people have been extremely aggressive about their marketing, and they've pretty much cornered most of the market. Most of the new transitions from other systems to a different provider, especially as hospitals are consolidated and are merged into larger healthcare systems, the Epic is become the vendor of choice. So the barriers are mainly between the various vendors, that if a patient goes to one hospital and then ends up having to get transferred to another hospital because maybe a service, a heart surgery or some kind of special treatment, cancer treatment, is not available where they are, when they go from one hospital to the other, many times the ability to recall all of the medical records and tests that have been done is lost. And so the barriers are in interoperability, are the fact that they have silos, that you have these massive hospital information systems that are very sophisticated, but they don't do a good job of talking to one another. And so our orientation now in the last few years has been to try to look at patient-centric care, that we're trying to look at it from the patient's perspective. And certainly the hospital systems are not very good at that. And what they would like to have with interoperability is that the patient's medical information should be vendor agnostic. It should not depend on which vendor you went to, which hospital system you were a patient at, to determine whether you can access in a flexible and usable format the data, all the medical information that's been acquired about you. And in addition to the individual patients, you have population health, especially when you have pandemics like COVID. We need to be able to identify public health concerns early and be able to share data at a governmental and public health standpoint. So we need to be able to look at the big picture. And the biggest challenge to America is the fact that we're spending $4 trillion. We spend twice as much. We spend a average of nearly $12,000 per person per year on American healthcare, and we need to figure out how we can match Canada and England and Germany and France. They all spend on average less than half the amount that we spend. And certainly this is unsustainable, that this is an incredible drain, and it would make a little bit more sense if the quality was better, if the access was better, if the patients weren't feeling abused. But unfortunately, the American healthcare, despite how much money and resource we invest, has the worst statistics in terms of outcomes, and patients are not feeling like they're getting the care that they deserve. So we have to find some way of using medical informatics to improve health outcomes. We should have equal access. We should have quality assured care for everyone. What are the 5 key elements to achieve interoperability? Well, first, we have to have adoption of some standards. There should be optimization. So we've tried to establish these standards with HL7 and now FHIR, and we know now that has not really been successful, in that all they've done is come up with standards about what individual fields we're going to capture and what the formats and what the rules are for how that data is captured. And that certainly is an important first step, but it is not sufficient to be able to make it where you can go from one hospital system to another. Somebody can just push a button and dump your record into a compatible format and then reload it into the competing hospital system that might use a different electronic health record. That would be ideal, and that is the goal. And in order to do that, we have to have the standards of how we're going to store the data. How do we capture the data? What is the format? And when you're dealing with entities such as hospitals and electronic health record vendors, they're not working in the sandbox together very well. So they're not very accepting of standards. The standards, as a matter of fact, we saw how HL7 has been a failure at being able to make it a transparent, make it easy for patient record data to be rolled out of one system and into another. And then they came up with FHIR, the fast. We'll talk about that in a subsequent slide, but it's they tried to come up with saying, well, we've got so many different variables and these non-relational hierarchical databases are very difficult to interface among each other. So we need to establish some kind of standards of how the data is captured and stored so that it's vendor agnostic. And that's where we're stuck. We have not been able to get the various vendors to communicate among each other in a way that allows the patient's data to be the patient's and not really the hospital systems. And one of the things the government has tried to do is instill financial and clinical incentives to encourage the various vendors to achieve interoperability. But unfortunately, this has not been very successful. And at the same time, with number 4, we have to protect the patient's privacy and the security of the data. So when you put all this together, we certainly have, like a war, we have rules of engagement that we have to come up with some kind of compatible standards that allows the patient to get the best care, and the tremendous investments we have in data capture and electronic health records needs to be coordinated to the patient's benefit. And that's where we stand. We're at a Tower of Babel situation where the various systems won't talk to each other. Patients are spending a fortune having all of this care delivered, and yet it's very difficult for the totality of the patient's care to be coordinated because of the incompatibility of the various data systems. And so one of the areas that is encouraging is that in order to capture medical data and be able to share it, we have to have some standards of what is the terminology, what's the vocabulary we use, what does blood pressure mean? Is that a systolic over a diastolic? Is it resting? Is it sitting? Is it the left arm? All of the various factors that go into capturing any piece of medical data has to have a standard so that you can compare apples to apples. And so in the field of medical informatics, one of the early entities is the International Classification of Diseases. We talked about that last week. And current procedural terminology, that's the various itemization of services that doctors can get and hospitals can get paid for, whether it's medications, whether it's medical services, operations, imaging studies, x-rays. All of those things are coded in the current procedural terminology code that's maintained by the AMA. SNOMED is a very interesting and very powerful, although underutilized in America, but SNOMED is an international classification of vocabulary that allows us to standardize the meaning of words, and I think offers us the best hope that if we all adopt SNOMED and use the power of the standardization of what do the various text items mean, what is the definition of each individual datum that can be in a medical records. SNOMED, I think, is the most sophisticated and most advanced vocabulary system. And LOINC is sort of a subsystem of that focuses more on the laboratory. LOINC was developed at the University of Indiana, Indianapolis here in America. I was involved with some of the initial development of that. LOINC was used because a lot of doctors' offices were using various laboratories, but they couldn't share the data because each laboratory had its own format for the milligrams and what the units of measure of each test were, and they came up with some standard, and it's been a tremendous help in trying to standardize how we share laboratory studies among the various electronic health record vendors. So our goal, of course, is to have vendor agnostic data representation. The big problem we have with the electronic health records is some of them are hierarchical databases rather than relational databases, and there's no software that you can develop that'll switch from a hierarchical to a relational. So we have a problem with the evolution from paper to electronic and the role of the electronic health record. So we have the government and industry initiatives that we've talked about, the Cures Act, high tech, all of those things have been strong supporters of going to electronic health records, but unfortunately it has not allowed us to achieve what we want, which is better outcomes at a lower cost. And so the only way to do that is with increased standardization, which everybody's fighting against. And now that we're down to just two major vendors, and pretty much the Epic folks are eating Oracle Cerner's lunch, we may end up just having one, and that will probably help solve a lot of the problems, but it won't make Larry Ellison very happy because Larry Ellison owns Cerner Oracle Cerner. So we need to continue to look to steps so we can achieve full interoperability so the patient data belongs to the patient. And so I hope that some of you in this class will end up being the leaders that figure out how to come up with a standard of representation of the patient's medical record, medical information, individual items of information that are independent of which computer system, which vendor is actually getting paid the big bucks for storing the data. So look forward to seeing you next week. We'll be talking about these about SNOMED and these data standards in more depth. I think one of the things that we'll be talking about is the what is needed to solve some of these Tower Babel situations. I think HIPAA has been a major impediment to medical research because of the fears of breaches have pretty much precluded any meaningful sharing of individual patient data among research organizations. It's been a big drag in the academic environment to be able to do meaningful research. So I look forward to seeing you next time, one day early next week.